multidisciplinary treatment programs as it stands and how we manage those patients with chronic pain. First, I'd like to start off talking a little bit about team-based care. This is not new to any of us. I practice team-based care in my community. We have 4 cats that we look after. 2 bartenders at Mike's, one of the staff in the Harbor House, feeding these cats, the assistants of care Cayman to make sure they were neutered and spayed. So as a community, we look after these cats. The benefit is they're well fed, they're happy, and they don't eat the birds. How many of you have children? Show of hands. See, you all practice team-based care. You can't raise children without a team. The saying goes, it takes a village, right? Multidisciplinary treatment programs are basically team-based care. So let's talk a little bit about that. It's not a new concept for medicine either. The first talk today was an oncology talk. Team-based care has been present in the management of oncology patients for as long as I can remember. So conceptually, it really does make sense. When we talk about chronic pain, I think it's important that we understand what it is. Generally speaking, chronic pain is something that persists for approximately more than 3 months, then any standard pathology should be anticipated. So let's say, for example, if you break your leg, we would expect that would heal within about 12 weeks. If you have pain 3 months after that period, then we start to worry that you have some form of chronic pain related to that accident or that injury. So it's quite a defined time period. Unfortunately, it also afflicts many, many people. Rates of chronic pain in the world are ranging from anywhere from 20 to 30%. So if you look at that in this room, that means this entire side of the house has chronic pain. It may not be entirely true, but that's close to the numbers we're talking about. So it's a lot of people that suffer with pain, many of whom suffer in silence. Patients suffering from chronic pain problems experience a multitude of concerns. Not only are they dealing with the pain problem, they're dealing with the disabilities and the impairments that are related to those. And they also have to deal with a lot of psychosocial issues. To a person, there's really not been anybody I've met in a clinical situation with chronic pain that doesn't have an element of anxiety or depression and doesn't have poor sleep. So there's a lot of factors involved in looking after these patients. The other factor for chronic pain is, as you know, there's been a growing concern over the years about the types of treatment that we offer chronic pain patients. One of those has been opiates for a very long time. And you can see very readily the impact of what opiates have done to communities now. It's estimated that about 20 million people in the United States have an opiate use disorder. That's a lot of people, all right? And that's probably underreported. So pain in itself is generally speaking something that can be quite helpful. If we sprain our ankle, that acute pain is protective. It tells us that we've done something to injure ourselves and that we should take steps to be careful and make sure that we don't cause further harm. Unfortunately, when you look at chronic pain, it's useless. It doesn't help us with anything. It's counterintuitive because it doesn't really create a situation that we can improve upon. It doesn't protect us. In fact, it just makes our lives miserable. So it's really quite unhelpful in that sense. The presence of long-lasting pain for many patients becomes a burden that will last their entire lives, and trying to manage and assist those patients becomes very challenging. It's really very difficult to manage a pain patient in isolation, and I think that's an important concept. The multidimensional aspects of chronic pain suggest that optimal outcomes are best managed using multimodal treatment, and we'll talk a little bit about what that is in just a few moments. I talk to my patients about pain using a couple of different sort of examples. One of the best examples I've come across so far is a triangle. And if you think about a triangle, at each tip of that triangle, the first tip is going to be pain, the actual underlying physiological problem. The other is going to be mood, or all the associated psychosocial concerns that go along with that. And then finally, there's sleep. And each of those interacts with one another in either an adverse way, or if we're fortunate and we can make some gains in improving them, a positive way. If you make sleep better, generally speaking, someone's mood is better. You know what you feel like if you've had a poor night's sleep and you've got a stressful day ahead of you. It's more stressful. So we look at pain in that sense and try and manage all of those aspects. I think this picture is particularly good at showing you the interrelationship between all of these features and shows you sort of how coping skills and how mindfulness and how sleep, how mood and anxiety, how the pain problem can all interrelate. Now, when we're managing these patients, there sort of is only one major goal, and that's to improve function. Okay? There's two ways to look at pain in itself, and I think, again, this gives you a good understanding. On the far side, you'll see somebody that's living a function-centered life. Closer to me, a pain-centered life. Most of the time when patients come to see us for chronic pain concerns, for assistance, they're living a pain-centered life. So they've had an injury or an illness or some form of issue that's come up. They start to have problems with persistent pain. That continues. They start to have difficulties with managing the pain. They may not know how to do it. They don't have the skills. They don't have the assistance, perhaps. Then they start to think about unhealthy sort of concepts like hurt versus harm. If I go and do something active, it hurts, therefore it's harming me. And that's false. The actually is opposite is probably true. If you're active, it makes things better for you, emotionally and physically. So you start to believe in these things. You start to get deconditioned. We get weak, tight muscles. We start to lose muscle. We have atrophy. And that makes the physical pain worse. We start to get fearful of what the future is going to be like. What's my life going to be like in 5 years if I feel like this now? How am I going to care for my family? How am I going to care for myself? And as you can see, you just end up reducing your activity, becoming isolated. People shy away. They feel stigmatized by having pain. They don't really voice those concerns very often to friends and family. And the next thing you know, they're hiding and they're living what we call a pain-centered life. Now, to get somebody out of that is very challenging. It needs a team, okay? The way we do that is we start to move towards a functional existence. So we start working with the team, the physiotherapists, the psychologists, the pain doctors, the surgeons, the allied health professionals, and we start to work on improving that person's life and understanding. We start to get them active again. We start to get them interacting in their community, perhaps getting them back to work. And keep in mind that at 6 months, if people haven't been back to work, there's about an 80% chance they're never going to go to work. So it's very important that we start to focus on these as outcome measures. To do that, we look at the use of a multidisciplinary pain program. Now, Roland mentioned something in the very beginning, which is generally, I think, quite true. It's wonderful to have all of the things we need in one house, but it's often unrealistic. So just because we don't have all the means to assist or all of the multidisciplinary disciplines in one facility, it doesn't mean we can't provide good multidisciplinary care. We need good cooperation between the different facilities to do that. We need communication, just as we would do in a single environment. So when you look at multidisciplinary care as a definition or as a concept, with respect to pain management, it usually entails a pain director or a manager, a doctor that's going to oversee everything. And the everything is the allied health professionals, that would be the chiropractors, the acupuncturist, the physiotherapists, the kinesiologists, the exercise therapists, the yoga teacher. You're also going to need the psychological concerns addressed. So you may have social workers, psychologists. In more severe cases of psychiatric burden, you may need a psychiatrist. You're also going to look to use occupational therapists in the community to assist people getting back. You may have to include employers, starting to examine how can we get these people back to work? What can we do in the workplace to perhaps mitigate some of the pain problems and allow them to work a full day or a part day? So you bring this team together, and then you all start working with the same aim. Remember, improving that person's function. This would entail meetings about these patients to talk about how they're doing, what are the problems that have come up, how can we address those problems. So it sort of becomes, as I said earlier, a team of people looking after that one individual. And if we do that, we generally see much better outcomes. I'm not going to go through all these, you can read those as well. So as you see here in more of a graphic form, multidisciplinary treatment is just that. It's multiple disciplines looking after one individual with one common goal and talking to one another about how we can meet those goals. So as I've said earlier here, we've got interventionalists, so that might be somebody that's doing an injection on somebody's spine to try and alleviate pain. We've got rational pharmacotherapy. When I say rational, that means using the appropriate medications for the appropriate problems. And yes, that means opiate sparing. We've got surgery in some cases. We've got our psychiatrists, our psychologists. We're trying to encourage people to make changes in their lifestyle, to make healthier choices. We're doing that with kinesiologists, physical therapists, and then of course we've got physical medicine and rehabilitation specialists. Some of the anesthetists practice chronic pain management, sometimes general practitioners, and certainly family doctors are very, very heavily involved in the vast majority of these patients. Interestingly, and this was something that David had brought about a few minutes ago, there's a financial benefit to multimodal care. The cost in the United States to chronic pain is approximately $500 billion a year. So that's care, loss of earnings, everything all rolled into one. So this is an expensive problem. There have been studies, this particular study came out of Canada, but there are other studies from other countries that show that multimodal care reduces the burden on society and reduces cost, improves function, and everybody wins. If we get people back to work, they feel better, and the economy is better. So it's really an excellent way of managing that. When you look at the studies on this particular problem, the outcome, in other words, functional outcomes, quality of life, etc., all show much more substantial improvements than just segregated individual care. So there's common reasons for doing this, and I think that we have to consider that as well. Multimodal programs can be very expensive. The McMaster University model in Ontario, Canada, has a program which runs 4 weeks. It costs $20,000 Canadian. I think that's about 10 Cayman dollars. I'm teasing. But in that sense, it's a very expensive program. But when we see 20 to 25% of those people returning to their activities of daily living, their independent activities of daily living, their employment positions, we know then that that is a good investment. So it's important to consider that. When you're looking at treatment options for chronic pain, there's a multitude of them out there. Anytime you go on the internet, you'll find so many different things that purportedly help. If we look at the evidence-based treatment, it sort of brings that into a smaller group. Passive care, for example, is not something we really want to foster in our patients. Passive care would be perhaps ongoing use of acupuncture or a TENS machine, electrotherapy. It's things that I explain to my patients, we do to you. And the problem with we do to you is it stops you doing for you, and it can generate some dependency on that. We're trying to create independence, not dependency. So passive treatment is something that we would reserve for maybe acute flare-ups of discomfort, but otherwise we want people to be active. We want them in the water doing aquatherapy, chair therapy, yoga therapy, weight training if it's appropriate, going for walks. It's all about getting people moving, okay? Given the depth of psychological dysfunction in these patients, of course, we have to manage that, and I've already explained. Generally speaking, we would do that with counseling, could be cognitive behavioral therapy, mindfulness programs. That's actually one of the reasons why yoga is such an excellent activity for people with chronic pain. Interventional strategies, as I've mentioned as well, can span from a simple injection of a pain-relieving medication all the way to a surgical procedure. So there are many different interventions that can be beneficial as well. Goals of management, again, I think we've discussed this to a degree already. We want people to improve their function. So that means improving their individual activities of daily living. An example of that would be housework. Their activities of daily living, an example of which would be self-care, bathing, washing, doing their laundry. And then finally, in some cases, trying to get them back to gainful employment. And that would be, sort of all-encompassing for that function. There are a number of return-to-work strategies that can be managed by the workplace, and as care providers, we can assist with that. We can tell the workplace the types of activities that we think that somebody's capable of and how we can moderately, slowly kind of get them back to doing the things they were doing previously. Certainly, as I've mentioned, and I don't mean to harp on this, but it's probably the most important aspect of chronic pain, and it's the psychological concerns. And then sleep. If we can improve sleep hygiene, in many cases, we can make a very big improvement for patients as well. We have to be careful with that. Many medications are not particularly good taken on a long-term basis because they alter sleep architecture. It's a whole different topic. But there are some things that we can do. Cognitive behavioral therapy has been shown to be one of the best ways of managing sleep dysfunction. Back to the psychologists again. I'm going to close off with just one sort of concern, and I think it's a concern that's shared. It's a world issue, and that's the overuse of opiates and opiate use disorder. Few families in North America are not subject to the problems associated with the overuse of opiates. As practitioners and as a health community, there are things that we can do to improve this. It takes a team, and it takes a community to do this. There are many things we can do. Duplicate prescriptions, where one prescription stays with the chart, one prescription goes to the pharmacy. Intercommunication between pharmacies and healthcare providers is critical. That means an electronic system whereby we can track patients and what they're being prescribed and who's prescribing it. Multidisciplinary care helps with that. This costs money, but the investment is worth it in the long run. In the provinces of Canada, each province has its own policies, and the best policy that's currently in place is in British Columbia, and it encompasses all of these factors. It's also the province that has the highest rates, so it makes sense that they're taking steps to correct it. As practitioners, appropriately screening our patients before we give out potentially deleterious drugs, opiates, is very important. That includes doing screening to see if somebody is at risk for developing an opiate use disorder, and there are lots of tools available to do that quickly and quite effectively. Continuity of care is also something that is beneficial in managing opiate problems. When somebody sees the same physician repeatedly, it stops doctor shopping, it stops multiple prescriptions being handed out for opiates, and that helps keep them off the streets as well. We're not the only kind of problem or source of this problem, but we are a large part of this. We can't stop underground labs from creating opiates and fentanyl, but we can stop legitimate prescription opiates from getting into the wrong hands with the right steps. So I think that's something we should probably consider. Finally, a community is only as healthy as its environment. And I'm going to waggle my finger here a bit. We have a 1% recycling on this island. It's a beautiful island. We can do better. Thank you very much.